Hello, everyone. Good morning. I'm Dr. Ortiz. I see people are saying hello from different parts, which is fun and exciting. Hopefully, you learned something from today's session, and please ask as many questions as possible. It's going to be difficult for me to answer immediately while I'm speaking, as I'm going to be in presenter mode. However, at the end, I'll try to answer as much as possible. Today, we're going to be talking about cerebrovascular and specifically about neuroendovascular surgery. I know that last week, Dr. Langer had a presentation on cerebrovascular that was focusing mostly in open surgery. Whenever we treat patients with neurovascular disease, the two options of treatment are either open craniotomy or open spinal surgery, or doing endovascular procedures. And when we talk about endovascular, they can be done anywhere in the body. What inside vascular vessels. So we go inside the vessels to treat the pathology that is causing the problem. As you can see here, these are procedures that are performed by either interventional cardiologists that can treat the heart, or peripheral interventional radiologists that treat other parts of the body, and vascular surgeons that can treat arteries or veins in the legs, arms. And for us, specifically for neuroendovascular surgeons, we focus in the treatment of problems of arteries or veins in the brain, head and neck region, and spinal cord. Everything navigating a catheter, typically from the artery of the leg, the femoral artery, or from the vein in the leg, the femoral vein, and we go inside the vessels of the body until we get to the, let's say, an aneurysm in the brain, and an AVM, which is an abnormal connection between artery and vein in the brain, or the same thing in the spinal cord. Me specifically, I focus in a very diverse group of problems that could be related to neurosurgery, could be related to neurology, could be related to ENT, because we do treat tumors in the nasal area, in the neck region, and as well as in the spinal canal. So when we work problems with the spine, we work together with neurosurgeons and orthopedic surgeons. And we do this in adults and children. Obviously, depending on the age group, people have different pathology. Older people are more predisposed to getting atherosclerotic disease or hardening of the arteries that lead to strokes. And those might require stenting in the arteries of the neck, stenting in the brain, or treatment of acute stroke. And when we talk about children, we're talking more of congenital vascular malformations, whether it's a hemangioma, a venous malformation in the head and neck, in the orbit, which are collections of blood that happen because of weakness in the wall of the vein, similar to when you see varicose vein in the leg, same thing, but in the head and neck region. Reason why they're more obvious in the legs is because they are below the level of the heart. When you stand up, the blood goes to the legs, and that's why they become distended. When you stand up and someone has a venous malformation in the face, venous blood drains down. When they're laying down, it becomes more prevalent, more prominent. So I'm going to be showing you some cases of recent procedures that we perform here, so that you get more familiarized with this type of problem and see if this is a type of field that you get interested in, and that you become curious about, and have more interest in learning, and then becoming a neuroendovascular surgeon in the future. Like I was telling you, it's all about the team. This Phil Jackson, previous Knick player and head coach for the Chicago Bulls and LA Lakers. The strength of the team is each individual member. The strength of each member is the team. And that's true for anything in medicine. Working with groups of people, different doctors, nurses, physician assistants, technologists, is critical so that you can perform better and do what's safest for the patient, help them the best you can. And in each of these procedures that I'm going to show you, obviously there was an entire team of people, not just doing the procedure, but deciding, should we do this procedure? Which way should we do it? Should we do open? Should we do endovascular? And when we do endovascular, which modality of endovascular? And I'm gonna go over some of the details. This is an example of a 49-year-old man who underwent surgery for obstructive sleep apnea. This is someone that was snoring a lot, so his wife was complaining about his snoring. And but on top of that, more importantly, when you hear about obstructive sleep apnea, people that suffer from that condition, they have different periods of when they're sleeping of having hypoxia and hypoxemia because they stop breathing for a period of time, even if it's a couple of seconds, and that has an increased incidence of heart attacks and strokes. And that's why management is important for this type of condition. And typically it starts with just a specific mask that pushes more oxygen into your lungs. But then if it becomes so severe that even the mask doesn't work, then there are different surgeries that maxillofacial surgeons perform to treat this problem. So he underwent this surgery, and this is a CTA, specifically a CAT scan with contrast, with intravenous injection of contrast. And this is what we call the coronal view, which is basically looking at someone from the front. So this is the left orbit, right orbit. See his nose here. And you can see what an extreme type of surgery it is. You can see here, all of these whites, this is metal holding together different pieces of bone in the maxilla and mandibula. And you can see the teeth, how they're really, they had to put all these screws to attach them together. It's a major reconstruction. And he was complaining of severe pain right after surgery, which is not uncommon after a surgery like this. However, he also started complaining of pulsatile tinnitus, which is he would hear pulsations in the right ear. And initially, the surgeons that took care of him didn't get concerned because he was just complaining of pain. It was a little bit weird for them that he was having that pulsatile tinnitus, but they waited, that the symptoms didn't get any better. They actually got worse. And he got at this CTA, and here is obvious to see an asymmetry of the vasculature. This is the left side, so this is the normal side. And on the right side, you see all these vessels. These are veins, enlarged veins that we shouldn't be seeing. Look at the left side. An easy way to interpret an MRI or a CAT scan, draw a line in the middle. What you see on one side, you should see on the other. And there's obvious asymmetry here. So we took him for angiography. And so we navigated the catheter from the artery in the leg, and we parked it in the right external carotid artery, the artery that takes blood flow to the face, scalp. And this is an anterior posterior view at the beginning of the procedure, and this is a lateral view at the beginning of the procedure. So what you can see here is that we're injecting contrast in the arteries, and at the same time as we're seeing arteries, we're also seeing veins. It shouldn't be like that. It should be our early arterial phase, mid arterial phase, late arterial phase, capillaries, early venous phase, mid venous phase, late venous phase. In his case, we're seeing the arterial phase at the same time as the venous phase. So we know that there's a connection between artery and vein that should not be there, which is a very common pathology that we see in our specialty, because whenever someone has an AVM, number one, we need to map it with an angiogram, which is this type of test. But at the same time, the ideal way of treating them, especially if they're in the head and neck region or the spinal cord region, is by doing an endovascular embolization, which is going to the point of connection between the artery and the vein and disconnecting them. And we can do it in different ways. In this specific case, we went with a little balloon catheter because the flow is so high. Remember, pulsations in the arteries, you feel your pulse. In the veins, you don't feel your pulse because in between them, you have the capillaries that dissipate the pressure. When you have a direct connection between artery and vein, that high flow is going straight into the vein, and that's what makes it get bigger. That's why you saw that CAT scan that looked with dilated veins, and that's why when we treat, we need to be careful because whatever we put in can go into the vein and then goes elsewhere in the body, specifically the lungs, when it comes down from the arteries in the neck, from the jugular, from the veins in the neck, the jugular veins. So in this specific case, we use coils, which are strings made of metal, of platinum. So this is in the AP view, in the lateral view. So you can see the coil mass that takes the shape of this fistula or connection between artery and vein. And so at the end of the procedure, you see beginning and end, beginning and end. So now when we do the angiogram, you only see the arteries that are supplying the back of the ear, the temporal region, arteries that go to the nose, all the arteries that go to the head and face region. So this is a type of treatment, endovascular coil embolization of an arteriovenous fistula that was created as a complication from surgery, from a procedure, or a side effect from the surgery. This one is similar in many ways and obviously has a lot of differences. This is a 55-year-old man that presented with right eye proptosis. It was swollen, the sclera was red, and he had double vision. This is MRI, back of the brain, right side of the brain, left side of the brain. This is left eye and the right eye. You can see how the right eye is protruding compared to the left. When we see someone that has this type of problem, we're always thinking, is there a problem in the orbit that is leading to this congestion of blood flow? And specifically, does this person have dilated veins in the orbital region that are predisposing him to have this? So the way to answer is by doing an angiogram. And this at the top, this is the baseline angiogram. This is the right internal carotid artery injection. So remember, his right eye was the one that was dilated. This is a lateral view. Top of the head is here, forehead is here. This is orbit, back of the head. We injected contrast in the artery, and we're seeing this dilated vein. That's the vein that goes in the orbit, the ophthalmic vein. And it's also draining down to the cavernous sinus and the inferior petrosal sinus that then goes into the internal jugular vein. This is the lateral view. On the same side, the right external carotid artery, this was the right internal, the right external, again from the side, top of the head, orbital region, back of the head. These are arteries that typically just go to extracranial or extradural circulation. And this is the external carotid artery dividing into the occipital artery, internal maxillary artery, superficial temporal artery. And again, you see that dilated vein because it's supplied by multiple arteries that are very, very, very small. You can see it's difficult even to count them that are going to this area and filling the vein, a direct connection that you shouldn't see between artery and vein. From the left side, he's looking at him from the front now. So left side of the brain, right side of the brain is here. We inject in the left internal carotid artery, and from the left, he's crossing the midline through the cavernous sinus and draining to the right ophthalmic vein. And from the left external carotid artery, AP view, anterior posterior view, top of the head, left side, right side, same thing. Many arteries connecting with that vein that goes to the right eye or drains to the right eye. So if we try to go through the arteries to try to cure this, it's going to be impossible because it's so many arteries. We cannot, number one, we cannot fit the catheters that we use into these tiny arteries. So what we do is we go from the venous side and we navigated a catheter from the femoral vein. So we had one in the femoral artery going up, one in the femoral vein, now going against the current and going all the way into that vein that was draining to the eye. And we put these coils, this in the AP view and this in the lateral view. And you see this shape of the coil in the lateral view is the same shape as you see here in the origin of that vein that was connected with the arteries. So at the end of the procedure, you can see here the angiogram of the right common carotid artery. So you see the AP and lateral view. So you see branches of the internal, branches of the external, and you don't see the vein anymore. Same thing from the left side. So you can compare here baseline and post, baseline and post, and we eliminated that connection. And his eye returns to the normal position and with normal vision. This is a little bit different now. This is a 36-year-old man with sudden onset of low back pain and bilateral leg weakness when he was lifting weights. When he comes to the hospital, this is an MRI. This is a sagittal view of a thoracic spinal cord MRI. These are the vertebral bodies. These are the discs in between the vertebral bodies. And this is spinal cord here. Typically, the spinal cord color when you do this type of MRI, this is a T2 weighted MR imaging. Typically, this is very dark. It's black in color. But you see is grayish and whitish in some areas. That's edema or swelling of the spinal cord. And there seems to be here something inside the spinal cord that looks like some blood products, something that bled. And the only way for us to investigate this is by doing a spinal angiogram, which is the same thing, navigating the catheter from the artery in the leg, and then going into each of the different levels of the vertebral bodies and looking for number one, the anterior spinal artery, because the anterior spinal artery is the artery that supplies the spinal cord in the front of the spinal cord. That artery, if it gets occluded, the person gets a complete paralysis from that level down. If it's occluded in the level of the neck, complete paralysis all the way down. If it's occluded in the level of the abdomen, complete paralysis of the legs. So we need to map that artery so that we know where it is and we avoid it. We don't want to touch it. And then we go and look for the abnormality to see if there's an AVM, an abnormal connection between artery and vein. And this is his angiogram here. In his case, we found the anterior spinal artery, the artery that supplies the blood flow to the spinal cord, and that artery is the one that has the AVM. This is a very enlarged artery. Typically, we don't see arteries that large supplying the spinal cord, but it's because it was supplying the spinal cord plus supplying this AVM. Different from the other AVMs that were acquired, the ones that I showed you before. The one in the right side of the face was because of surgery. The other one, the dural AV fistula draining through the dilated vein of the eye, that's typically acquired from some kind of trauma. And it could be something as serious as a car accident or a fall hitting your head. And sometimes much minor trauma can also predispose to the formation of those AV malformations. However, this one is inside the spinal cord. This is not from trauma, this is something congenital. He was born with this, and by chance, then it presented when he was doing some Valsalva maneuver, holding his breath, lifting weights. It presented with hemorrhage and swelling, but we know that this has been there since he was born, or from very, very early onset of life. And so we navigated a catheter, we went inside this, all the way to the AVM to see if we could get with a position of the catheter in which we could inject a liquid embolic agent, like a medical crazy glue, to disconnect the artery from the vein. Now, this is a very risky area, because like I told you, that artery that supplies the spinal cord, if we close it, it's going to be irreversible. So we do what's called neurophysiologic monitoring with provocative testing. And what does that mean? We go with the microcatheter and we inject an anesthetic, lidocaine, and we inject a sodium amytal, amobarbital. And we see what happens with the potential. There's someone in the room, a neurophysiologist, that is measuring the muscles and nerve activity throughout the procedure. And when we inject this medication, we see, is the person getting some weakness or decreasing sensation potentials, or is it normal? In this specific case, yes, he had a significant decrease in the potentials, so we could not embolize. We could not inject the glue. An anesthetic is temporary. The effect wears off in 5, 10, 15, 20 minutes at the most. Obviously, if we inject a glue, it's going to be something permanent. So we did not inject glue. He went for surgery. And this is the actual picture of during the surgery, the exposure of the arteriovenous malformation. And this is doing an injection of a dye, ICG, and looking under the microscope to see the anatomy of the malformation. And this is done as a baseline test. And then when the surgery is completed, again, confirmed by making sure that you don't see any of these connections between arteries and veins, because the dye is injected in the vein and it's going to be redistributed throughout the body. And then you look for it under the microscope in the same area where you saw this as a baseline to make sure that you eliminated the entire shunt or connection between artery and vein. And then we need a confirmation by doing an angiogram. This is an injection of contrast in the same artery as you see here. So you see that it is very slow now. It is not as large as it was before, and it's filling all the way the anterior spinal axis, or the normal supply to the spinal cord, without evidence of AVM. So there's a combination of procedure of doing endovascular workup with the definitive treatment being open surgical exposure. This is another case of a 61-year-old man who was having headaches and seizures. And he went to the emergency room and eventually went to a neurologist, and they ordered this MRI of the brain. And here is the abnormality. We see prominent vessels in this area that you don't see elsewhere in the brain. You see here how dilated. This again a T2 weighted image in which the CSF, cerebrospinal fluid, looks white. The normal brain parenchyma looks different tones of gray, and vessels look black, like this a vein here. You can see these vessels here, and a vessel here, but obviously this is much more prominent than the rest. So there's some abnormality that needs further investigation. So we do an angiogram. And this at the top is the angiogram at baseline. This is an AP view, anterior posterior view of the right internal carotid artery injection. This is the artery, and we have a dilated vein of Galen. At the same time as we're seeing this arterial supply, we're seeing the vein opacifying because of connection from this basal tentorial artery. The same type of view, AP view, but injection this time of the external carotid artery, and you see enlarged middle meningeal artery branches going to the same area, to the dilated vein of Galen that then drains to the normal sinuses. Lateral view of the vertebral artery. This is the artery that goes in the back of the head, and same thing, dilated. When top of the head is here, forehead is here, back of the head is here. This is a lateral view of this same vein. So you see the dilated vein of Galen. An important feature that we are seeing here is these veins here, all of these veins here that don't look as obvious as this large one. Those are cortical veins, or veins that drain into the brain. So this is someone that has a very high risk of bleeding in the brain, number one. And number two is someone that has a very high risk of seizures and cognitive impairment, because the normal veins of the brain are congested, they're competing. The brain wants to drain through those veins, and this fistula, this AV, arterial malformation, fistula is the connection, wants to drain through that same vein as well. So they're competing. These are left internal carotid artery lateral view, similar opacification of that dilated vein of Galen, and an AP view of the left external carotid artery, again, showing the middle meningeal artery branches going to the vein of Galen. So we injected onyx. We went through this dilated middle meningeal artery all the way close to the vein, and we injected this network of onyx. Onyx is different from glue that I mentioned before. Glue is an adhesive. Onyx is a cohesive material, meaning that it closes the vessel, but it doesn't harden as quickly as the glue. So we have time to inject this substance. An injection like this took like an hour of injecting this material onyx. It looks dark like this on their x-ray because it has tantalum powder mixed with it so that we can visualize it. Otherwise, we couldn't see it. Everything that you see on their x-ray needs to have some coating for us to be able to visualize it. Otherwise, look, we don't see the brain in this. You only see the skull, the bone. So you need to, whatever we use, coils, coil is metal, so you're going to be able to see it on the x-ray, and tantalum is a metal, so it's powder of the metal mixed with the cohesive material, with the onyx. And this is the AP view, lateral view, and at the end of the procedure, you can see here, this is the right internal carotid artery, this is the baseline, this is at the end, right external, baseline, and at the end, vertebral artery, baseline, and at the end, left side, baseline at the end, and left external, baseline at the end. So we were able to disconnect the artery from the vein and take care of his problem. He has been asymptomatic and doing very well since then. This is something a little bit different. This is that type of malformation that I just showed you is something most likely congenital. However, this one is something acquired. This is a 32-year-old man that had a car accident more than 10 years ago. They saw him at the hospital at the time and discharged him. And then he started having some headaches and seizures. And this is his MRI. Again, this is an axial view of T2 weighted image. As you have heard me saying, T2 weighted many times here. For neurovascular disease, the T2 is much more useful than the T1 image in most of the cases. So because the vessels are very obvious in this type of picture. And again, left hemisphere, right hemisphere, back of the head, forehead. And you can see here that there's an obvious asymmetry and all these darker structure, those are veins that are dilated. Look at this dilatation, very large here on the left side. So this is someone that definitely needs an angiogram. This is a much more complex type of picture than the one I showed before. This is a left internal carotid artery injection. This is AP view on the top, lateral view in the bottom. You see the ICA, and then what you're seeing here is a dilated vein. So this person, because of that car accident, developed a direct connection between the ICA, the internal carotid artery, the artery that typically supplies blood flow to the brain, and the veins. There's no supply here to the brain, zero. There are no arteries going to the brain because there's a hole between the artery and the vein at the level of the cavernous sinus. And it has been so long that look how dilated these veins have become because they haven't been treated and the veins are not made to sustain that high pulsation. Look in the lateral view how large that vein is. And everything that you see on top, those are dilated, congested veins They're varicose. They're very irregular and dilated because they're competing again, trying to drain the normal brain and trying to drain this fistula. That's why they get so dilated, and that's why the person gets headaches and seizures. So we went ahead and closed the connection, but with these coils, strings made of platinum. And this, you see here, stagnation of contrast inside the vein at the end of the procedure, because we occluded the artery. He didn't need that artery because it was only going to the fistula. And we confirmed that here with an angiogram at the end. This is the right carotid artery injection that supplies blood flow to the right side of the brain. He has a good anterior communicating artery that crosses from right to left and then supplies the left middle cerebral artery. You can see that there is displacement, upward displacement of the left middle cerebral artery compared to the right, that is much lower down. And it's because of that dilated vein that we just treated. And this is a vertebral artery injection, again, in the back of the brain, that has a good posterior communicating artery, a connection from the left posterior cerebral artery, posterior communicating artery, and then supplying the left middle cerebral artery. You see this artery is the same as this one. So fortunately, he was born with a competent circle of Willis, good connections between the right and left side of the brain through the anterior communicating artery, and good connections from the back arteries in the back of the brain and in the front through the posterior communicating arteries. And that's why he tolerated not just treatment, but years of living without blood flow from the left carotid artery going to the left side of the brain. This is different from what I've been showing you, which were mostly arteriovenous malformations. This is someone has a brain aneurysm. Brain aneurysms typically form after people are in their 20s and 30s, 40s. It's rare that we see a child with a brain aneurysm. Typically when the child has a brain aneurysm is maybe traumatic, something that was related to some injury in the head and or some congenital collagen pathology. And so this young woman presented with migraine headaches. We knew she had lupus. And as part of the workup for headaches, she underwent an MRI and MRA of the brain. This is the axial view of the MRI of the brain. And we can see here that there's some dilatation. Typically, the arteries look like a little circle or cylinder. This is a basilar artery. And we typically see a complete circle. But here we saw something that looked different from typical. And this is an MRA showing that she had this dilatation of the artery. That's an aneurysm. Aneurysms they get formed because of weakness on the wall of the artery. And there's a ballooning or dilatation of the artery that the concern is, since it is a weak spot in the artery, it can potentially lead to rupture, to bleeding. And when people have bleeding in the brain from or in the head from an aneurysm, it is an emergency. 1 in 3 people, 33% of them die from that bleeding. Of the people that survive, approximately 33% recover and are well to have a regular life, and 33% end up with severe disability or in bed, bedridden, wheelchair, some type of disability. So obviously this is something that we like to take care of, because we can have a significant impact in a patient's life and their families of these patients. And to be one of the major focuses in our practice is really have an entire team dedicated to taking care of these people, either brain aneurysm before they rupture or brain aneurysms after bleeding, and then having to treat them and managing all the side effects after bleeding. So she got referred to us. In order for us to have better visualization of this, we had to do an angiogram. And the angiogram, these are 3D angiogram, 3D angiography. These are 2 different views of the same. And you can see the dilatation that was seen on that MRA, but also she has another one higher up. And then this is a small fenestration. She was born with this, with a little disconnection between two sides of the basilar artery. The basilar artery gets formed at the fetal stages because of fusion of the extension of the vertebral arteries inside the brain. So when we see something like this, like fenestration means that a short segment was unfused during formation of the basilar artery at the fetal stages. And this is another view, as I was saying. This is the little upward, higher up bubble or aneurysm. And this is the one lower down. Aneurysms can be saccular, meaning that just a bubble coming from, let's say, a bifurcation or a point of weakness in the artery, or fusiform, that involves the entire segment of the artery, not just one side of the wall of the artery, but the entire artery on all sides. This type of case, we treated with putting a stent, a flow diverting stent. This is how the stent looks under X-ray. And what it does is that it diminishes the amount of blood flow that leaves the stent going into the aneurysm, and diminishes the amount of flow going from the aneurysm inside the normal circulation, and has open ends at the distal end and proximal end to allow blood flow to go through. And as time goes by, there's aneurysm thrombosis, and this is the follow-up angiogram 6 months later, showing that the aneurysm had gone away and the vessel had remodeled. This is a follow-up MRA 2 years later after treatment, just to confirm that there's patency of the artery and that the aneurysm is gone. So that's a typical treatment of endovascular treatment of brain aneurysm using flow diverting stents. This is another recent case of someone that presented with subarachnoid hemorrhage. Subarachnoid hemorrhage is a type of bleeding that when we see it, we have to look for an aneurysm, as that's most likely the culprit. And like I mentioned before, the prognosis of rupture of an aneurysm is so poor that if someone survives, it becomes an emergency, because that means that if they rupture again, they might not be as lucky. So this 71-year-old woman had a sudden onset of occipital headache and neck pain. And when she came to the emergency room, she had this blood collection in the subarachnoid space, in the upper cervical region, lower brainstem region. We took her for angiography, again, to look for an aneurysm, and we found this. This is a left vertebral injection, AP view. We injected in the left, and the normal blood flow goes to supply the basilar artery, posterior cerebral artery, superior cerebellar arteries, anterior inferior cerebellar arteries, right vertebral artery. However, there's something here that shouldn't be there. And this is a connection between artery and vein, an arteriovenous malformation, with some direct supply from this vertebral artery. And this is the anterior spinal artery, the one that we talked about on the spinal cord, the anterior spinal artery that continues. This is a normal size, this thin line that you see at the bottom. But here is enlarged because it's also supplying AVM. And very important to mention, I told you that aneurysms are typically the cause of subarachnoid hemorrhage. Because of the high flow of this AVM, this person developed an aneurysm. This is a weakness in the angioarchitecture of the vessel. This is the aneurysm. And we need to, number one, treat the aneurysm to prevent bleeding again. And ideally, if we can cure the AVM completely, great. An AVM in this location most likely was something congenital that she had, not something traumatic. So we navigated the microcatheter. We went first for that artery that was coming off the left vertebral artery. We injected contrast. We did provocative testing, just like we did in the other case with the spinal cord AVM. In this specific case, there were no changes in monitoring. And the anterior spinal artery, we did, you can see here, we went into it. We see the aneurysm. It was very challenging to get it to make this turn and get into the aneurysm. So, and the wire could do it. We typically put a micro wire inside the microcatheter to guide us. The wire could make it, but the catheter was larger than the entrance to the aneurysm. So we went all the way down here It did the provocative testing. She didn't have any problem. We went further in, and in this case, we injected NBCA, N-butyl cyanoacrylate, which is medical crazy glue. And this is how the glue cast looks. We have seconds to do this. It's a team. So I'm injecting the glue, and I have an assistant that has to pull the catheter out as soon as the glue closes the connection, avoiding glue from coming back because it can cause a stroke if the glue comes back, and making sure that the glue doesn't keep going forward, or it can close the normal veins as well. If we wait too long to pull the catheter can get glued. It's like crazy glue. So the catheter can get glued, and then we cannot remove it from there. So we have, this procedure takes hours just to get there. And when we inject the glue, it's 3 seconds that we have approximately, depending on the case, depending on the consistency of the glue, and then it has to be pulled out. So it's a very intense moment for everyone involved. This is how the glue looks. It's mixed with the thiodol, lipiodol, which is also radio opaque, so you can see it on their x-ray. And at the end of the procedure, this is the angiogram from the left vertebral artery injection AP view. You don't see the AVM anymore, and you don't see the aneurysm anymore. And in this lateral view, you can see the anterior spinal artery and the posterior spinal artery. The spinal cord is right here in this space. This is the glue that we injected, but we need to confirm that the arteries continue to be normal. And she's doing very well. She didn't have any more bleeding, and she recovered without symptoms. So one more case to finish. This is a 65 years old man that presented to the hospital after he had been experiencing some mild weakness on the right side of the face. 27 hours is the onset of symptoms, comes to the emergency room, and he's found to have this occlusion of the left middle cerebral artery. The arteries, the left side of the brain give blood supply to the left hemisphere, and the left hemisphere controls the right side of the body. So he has right facial weakness because of some decrease in blood flow to the left hemisphere. He has an occlusion of the M1 segment of the left MCA, as seen on this CTA, the CAT scan with contrast. We did a CT perfusion, and the CT perfusion can measure in this side of the screen. You can see whatever territory has irreversible completer infarction is here, and this green is what is at risk of potentially getting a stroke. When we see someone with mild symptoms like that, some minimal facial weakness, and presented late, meaning more than 27 hours after the onset of symptoms, then we need to outweigh the risks and benefits of a procedure. Should we go in and try to open this artery through the catheter, or should we manage him medically? And initially we decided, let's manage him medically, keep him in the intensive care unit, making sure that the blood pressure is on the higher side, and see if he tolerates. A lot of people live a normal life with blockages of arteries in the neck and brain because they have good collateral circulation. And to that point, it seemed like he did have good collateral circulation. However, 8 hours later, while he was in the hospital, he decompensated more. Now he became agitated. He had trouble understanding what people were saying. He had trouble expressing. He had slurred speech and some weakness now on the right arm and leg, not just mild face. So we took him again to CAT scan, and the CAT scan showed again the blockage of the left middle cerebral artery. And you see this, this is all artifact from movement. He was so confused that he was moving his head all over the place. So he has motion artifact. We repeated the CT perfusion that again showed that there is no evidence of completed infarction, of irreversible infarction. However, there is territorial risk like before. And so this time we did a CAT scan also just to make sure that there was no evidence of stroke, and there's none, and no evidence of bleeding. Well, we took him for mechanical thrombectomy. A mechanical thrombectomy is the procedure in which we navigate the catheter, go to the area of the occlusion, and we have options of either opening the artery by using an aspiration catheter, opening using this stent retriever. It's a stent that instead of leaving it there, we pull the clot out, and sometimes we do a combination of both. In this case, you're gonna see the combination of both. This is the actual procedure. So I'm here with my assistant. He's the manager of Neuroendovascular at Lenox Hospital, Guillermo Restrepo. I'm navigating the catheter. You can see the catheter here going up. This is these are the clavicles. This is the neck. I'm going with the wire, like I mentioned before, and then the catheter follows the wire. I need to go as high as possible, as long as it is safe. The higher I go with this guide catheter that is coming from the artery in the leg, from the femoral artery, the better the chance of us having good control. We inject contrast through the catheter, and this is AP view and lateral view. And here you see the stump. There's an occlusion here at this level. He has good collateral circulation, and that's why he tolerated all these hours, because you can see the blood flow from the anterior cerebral artery coming around the hemisphere and trying to compensate for the blockage of the middle cerebral artery. This is the M1 segment of the left middle cerebral artery. This is the internal carotid artery. 95% of people, the left hemisphere is the dominant hemisphere, meaning that the left side of the brain controls language, calculation, and that's why people get aphasia, inability to either express themselves or understand because of decreased blood flow in this area. So now we're going to navigate the microcatheter to go cross this area. We need to cross the occlusion in order to put the stent, and we're putting it through the aspiration catheter, an aspiration catheter that we're going to keep here at the origin of the occlusion. We're trying to be as fast as possible because time is brain and every second matters. So navigating this is the micro wire. We're crossing now the lesion with the micro wire. Now we're crossing with the micro catheter that we're gonna keep in this place, and and the aspiration catheter is here. So we go to the place that we want it to be. We remove the wire. Now we're gonna connect that catheter to a flush so that we have lubrication. And these are hydrophilic microcatheters, so they need to be wet. Otherwise, they don't navigate as well, and we cannot navigate our devices as well. Now we're navigating our the stent retriever. Guillermo is advancing it inside the microcatheter, and that one we're gonna park it here. I'm connecting the aspiration catheter as Guillermo is doing the other. So that way we start doing aspiration ahead of time. Now we're aspirating from this one, and not just if we aspirate the clot, but also when we put the stent, we diminish the risk of losing some of the clots that cause the blockage into other circulation. Now this is the stent, is getting to the place. We unsheath the stent. We're unsheathing. We leave it there for a few seconds, and then Guillermo is aspirating with a large syringe. I bring the stent inside the aspiration catheter, pull the aspiration catheter out of the body, make sure that there's no clot left here in the hub of the catheter, which sometimes can get dislodged. And then we do an angiogram to confirm, and this the baseline here, and then at the end you can see normal blood flow to the left hemisphere. So we had complete reperfusion, and he had a completely normal recovery. He didn't even require rehabilitation. He went home after being discharged from the hospital. So like I mentioned at the beginning, it's about a team. These are my partners. I'm very fortunate to work with people that are very talented, people that care tremendously about the patients, and people that care tremendously about each other. And our strength is really that we have each other, and can help people in any possible way. Thank you for your attention. That's what I had to share with you. And now ready to answer any questions. Let's see. I'm gonna start here at the top. Good morning, everyone. Hello. People saying hello from Jacksonville, Florida, La Paz, Bolivia. Hola. From California, Ecuador, Houston, Texas. I'm having trouble understanding how exactly to identify a point of connection between vein and artery. Yep, it is challenging it takes time, it takes experience, it takes years of training, it takes years of practicing and doing the same thing over and over and over and over. So yes, the first time you see this, or the second or the third or the fifth, you're not gonna get it. It's typical, so don't get discouraged by that. It's just like anything, repetition, 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 studying a lot, working hard. And we just know in an angiogram that there's an obvious abnormal picture when we see an artery and the vein at the same time. However, we, yes, need to look for the actual connection. And that takes a lot of understanding of anatomy and figuring out after understanding many angiograms. How do you identify the location of the fistula? Same answer. How do you differentiate between the vein and the artery in the angiogram? Same answer. How do you not just puncture either a vein or artery when pushing the catheter so far, especially when it's so bunched up? Yeah, so again, it's a lot of training and understanding the complexity and the risk of every procedure we perform. Yes, if an artery or vein gets punctured, the patients can die. So everything that we do has to be very well measured, monitored, supervision, training, caring, paying attention to detail, and anatomy. If anyone is interested in anything related to medicine, anatomy. Nowadays, we have great technology with MRIs, with great technology with angiography, robotics, many things that we are doing that help us to diagnose problems. However, the one that knows the anatomy the most, that's going to be a better doctor than the one that doesn't, because it is about making sure that you are helping that patient the best you can. And these years in school, in high school, college, medical school, residency, fellowship, and even as an attendee, you need to continue to study to be able to avoid complications. Years of training experience plus good level skills. Off topic, have you noticed any difference in patients who eat meat and patients who do not eat in their arteries, nerves, etc.? Yes. I have seen that people that have poor nutritional habits do get sicker at an earlier age than those that don't. And they get more hardening of the arteries, more narrowing in the arteries in the neck, narrowing the arteries of the heart, narrowing the arteries of the brain, narrowing the veins of the legs, narrowing in the arteries of the legs. So healthy eating habits are critical to have a healthy lifestyle. Obviously, we will all get sick and one day. However, in the hospital, the people that have poor nutritional habits, we see them at much earlier ages. We see people that are in their 20s with obesity, diabetes, high cholesterol, strokes, heart attacks, all because of bad diets. And in terms of specifically meat, it's a balance. You can eat lean meats. It shouldn't be every day, shouldn't be every other day, should be with less frequency. Ideally, more vegetables, more fish, more turkey instead of chicken is more balanced than red meat heavy diet. What is a DW image? Is diffusion weighted image, is the image that, or DWI, is the type of picture used to look for acute strokes. When we have T2s, we have T1s. The DWI is based out of T2s and is looking for any acute stroke pathology and can also identify infections. I can see the doctor's screen. Is it just me or something went wrong? I only see his camera feed. Hopefully the rest of people saw everything else. Thank you, very cool. How is it possible to navigate so precisely with the catheter? Answer like before, time, and good mentors, training with the right people, making sure that when you have an opportunity to train, look for the best places, shoot for the stars, look for who is a pioneer, look for who is curious, look for that person who wants to be a mentor and help others. Gracias, doctor. How do you cope with losing a patient? How do you unwind? Yes, when something bad happens, it is horrible. It's extremely sad, and I have to say that the good doctor feels it because he's human. And it's trying to figure out how you can do better the next time. It is about communicating, having someone to talk to, having a support at work and at home, so that you can really learn to adjust and to help patients better the next time. Every time I treat someone, I think about it as if I'm treating my wife, parents, kids, cousins, nephews, brother, sister, grandparents. How would I feel if they were in somebody else's hand? And that brings a lot of humanity to the care of what we do. Thank you so much. Thank you. When is it appropriate to clip an aneurysm? The great majority of the aneurysms are treated endovascular. Sometimes the complexity or shape or size of the aneurysm makes it more amenable for clipping and safer for clipping. In our hospital, 25% of aneurysms get clipped, 75% get to endovascular treatments. In Europe, 90% plus of aneurysms get treated by endovascular techniques. Some sites in the US still do more or 50-50 clipping. That might be because they have more expertise in clipping at those sites. Do you only do endovascular procedure if the aneurysm ruptures during embolization? Me personally, I only do endovascular procedures. If an aneurysm ruptures during embolization, you need to keep treating it, because remember, if you're trying to prevent a rupture, so if you're coiling an aneurysm, keep coiling the aneurysm. And you do a CAT scan right away on the table. And if there is blood, the patient might need a ventriculostomy to release some of the pressure in the head. If coils or glue that are used in treatment come loose, can a stroke occur? How often does this happen? Yes, a stroke can happen if this becomes loose. In good hands, it shouldn't happen, so shouldn't happen at all. But if it does happen, you need to try to retrieve the coil and take it out of the artery. And if it is a glue, you cannot dissolve it. Thank you. How many years in training is needed for this kind of interventional specialty? So you do your 4 years of college, your 4 years of medical school, and then depending, you can do either 4 years of neurology residency followed by 1 or 2 years of stroke and neurocritical care fellowship, followed by 2 years of neuroendovascular surgery, and then you can practice, or doing 7 years of neurosurgery followed by 1 year of neuroendovascular surgery, or doing 5 years of radiology followed by 1 year of neuroradiology and 2 years of neuroendovascular. So it's 8 years of training after medical school, regardless. We still have other questions here. I know that we're ready to finish my session.
Thank you so much. If they have more questions, would it be possible if they could email you?
Sure, let me put my email address here.
Perfect. Thank you. Thank you so much for your time.
I have a Twitter handle as well, and I have LinkedIn if anybody is interested, so I'll put it on the chat as well.